Hi, my name is Connor Howes and today I'll be completing Practical Assessment 23, setting up for catheterization and fluid therapy and connecting patients to fluids. So we're here in the laundry now and I'm just going to wash my hands to create a microbial barrier between me and the fluids that I'm setting up. So our clinic uses chlorhexidine gluconate as our hand wash. So we do 2 decent pumps. It has been diluted. Running water. We just want to wash our hands for at least 20 seconds, getting in between all different areas. Great, and now I'll go and dry my hands and I'll come back. Now I'll just apply minimal PPE here, being disposable gloves. This helps to create a microbial barrier between myself and the fluids that I am setting up to ensure that no dust contaminants or foreign debris come into contact with the fluids. So I've correctly gathered all of the appropriate equipment ready for today's video, including the giving set extension line and the Hartmann solution that we will be administering. So, before we begin, we want to check over all the package integrity and sterility of the equipment here. So I'm checking that the peel hasn't come away from the edges at all. There's no holes, rips or tears coming through. There's no air pockets, and it is within expiry, and I'm very happy with that. Then we do the same with the extension line, checking the peel side, making sure that it has not come away, and that one is all within expiry as well. Next, we'll do the fluid bag here. So we're using the Hartmann solution, and we want to be checking the packet for package integrity, making sure it has not come away at all, and we are maintaining acceptability, and it is with an expiry being September 2026. We'll first open from the bottom here, and the tear side that the fluid bag has there. We then want to gently remove the fluid bag out of the packet, turning it upside down, and we first place it over the hook. We want to just gently open the giving set, making sure that it does not come out of the packet and remains in the packet whilst we are setting up for fluids. Then we do the same with the extension line. You can touch the spike cap here, but you cannot touch the spike itself. You can touch the outside of the bag surface here, but you cannot touch the ports itself. You can touch the roller clamp here, but you cannot come into contact with any of the port here once the cap has been removed. Then I take the end cap here, unrolling the extension line. Now, being very careful at this stage, removing the end cap, placing it down on top of the paper. It has not compromised sterility. Now, that end port cannot be touched as I have opened it. I'm holding the cap, I am not compromising sterility. I am placing the cap directly on and tightening it. Then, we're going to grab our cap here and gently placing it on top, maintaining sterility. That one can still be used and capped later, and we do place it on top of the IV line as per our clinic policy. Making sure that the port is clean and sterile, removing the spike cap end. We cannot touch this spike end now. And gently placing the cap end into the fluid bag. Just attach the giving set there into the fluid bag. I will then clamp off the roller clamp to ensure that no fluids come out of the line whilst I'm getting myself prepared for priming. We undo the roller clamp to prime. So I like to prime directly over a bin here without removing the cap. I've unclamped the roller clamp completely, and I'm now checking the entire fluid line for any air embolism, and we want to remove all of those air bubbles, as air bubbles can kill. Now I'm checking the entire fluid line at this point. I see another bubble just coming out, so we just keep on priming until all of those bubbles have been completely removed. So the fluid line has all been primed there. We have not removed the end off the cap at all. I will just remove the extension line now over the neck, and being very gentle and making sure that we aren't agitating the fluid line in any way, and we're just coming over and hooking it. So today being the 10th of June, and my initials being CH. That now shows that every nurse or the clinical team within the hospital that I've aseptically opened the bag on this day, and that gives it for a period of time before the fluids have to be thrown out. So this is Lexi Howes here. She's a 4-year-old, 3-month female spayed caboodle, and today she is my simulator patient. So today I'll be placing a 22 gauge blue catheter in the right cephalic vein of Lexi Howes. The 22 gauge catheter was chosen as it does not lacerate the vein. It causes minimal trauma upon insertion as a result of the smaller gauge bevel that we are using. It is a very versatile catheter that allows for fluid therapy, blood sampling, and drug administration all through the intravenous vein. Now, the cephalic vein was chosen for its easy accessibility on the forelimb. It causes minimal stress on patients and is usually used for shorter-term care patients. If Lexi was requiring longer-term fluid therapy, then the saphenous vein in the hind limb would have been chosen. However, we have chosen the cephalic vein today as it reduces the risk of contamination compared to the other veins in the hind limbs. So before we begin, we have correctly gathered all the appropriate equipment required for today's catheter procedure. Our clinic does not use any comfy pads or injection ports. We go directly into the vein and they attach the fluid line directly into the catheter that way. Now, with some clippers, we just want to lightly clip the area where the cephalic vein is. We want to make sure that we are clipping all the way around the limb. It has already been clipped here, but I would just give it a decent clip just to make sure it's a completely hairless barrier and that no hair can stick to the tape in any way or cause any contamination and maintain aseptic presentation. Got a couple of metho swabs here. As per clinic policy, we use 100% metho in our metho swabs here. It is ideal that we use a 70-30 chlorhex metho ratio. Okay. So again, before we begin, I'm going to crack that one open, removing the end there, loosening the catheter hub, making sure that we're not coming into contact with any of the ports, as the catheter hub must remain sterile, and the parts that must remain sterile are the stellate and the catheter hub when we insert. So I've correctly cleaned the site there. I will hold off to see the vein, putting the bevel up straight so it goes directly in when I place the catheter, so it's in one swift motion. Coming in at a 45-degree angle, we want to make sure that we're coming into the vein, going going low. Yep. Inserting, sorry Lexi, yep. Waiting for a bit of flashback. I don't know if you can see that. And I'm in, yep. You can see the blood coming. I'll ask my nurse assistant to hold off, holding the vein, holding the leg at the same time. We can discard that one in the sharps container and I will hold on. Just be a little bit difficult here for me.
Just go straight over the top.
So you don't, okay? And just to tape it in place, I'll go over the top, making sure I'm not covering the hub in any way, as we still want to connect to the fluids there. We just do the one piece of tape as per clinic policy, and then we get our soft band here, place it underneath, go around the leg joint here. So we've created quite a good bandage. You're doing such a good job, Lexi. And then from the top, going around with the vet wrap. And putting a little tab on the end, we will remove the vet wrap bandage just so we can have access to it. And I will rebandage him up once we connect him to fluids. Removing the catheter hub. I've got my nurse assistant holding off so no blood flow is coming through. I then will undo the fluid line here, removing this aseptically, and I am not touching the hub in any way, the port here. Then we are inserting the fluids in, getting the fluid line just up here, and using the other bit of tape which we have here, we will connect, we will tape that in place so the fluid line cannot come out. Great, and then I like to just vet wrap this one just for her, just so she can't access it, lick at it, gnaw at it, or chew out the catheter in any way. We are all set there. That is aseptically ready. I'll come over to the fluid line. We'll just turn it on. Her weight is 8.4, and the vet would like a maintenance fluid rate of 40 today. We're gonna bring that right down from 73 here all the way to 40. We are then going to select the time, keep it as the time to allow. Volume to be infused, we do that as 900 just so it slowly decreases down as we are doing the fluids. Run that one. Clear the volume infused as we have infused no fluids. Select that one, it is running now. I am just gonna take Lexi here in a correct hold. So I will have her here. As you can see, she's under my arm. I've got a good grip on her. She's under my thorax. We will bring her with us and we will take her just to the cage here. Great, and we get her all safely set up in the cage. Now that I have safely returned Lexi back to her enclosure, I'll monitor for any signs of reaction or clinical signs of pain or discomfort. I will ensure that the fluid rate is appropriately flowing. The roller clamps have been unclamped at both ends. There are no signs of kinks or the fluid line getting caught in the door in any way. It is appropriately hanging and it is not sitting on the ground, causing any contamination. And there are no signs of any air embolism as well. We want to make sure that the fluids are going intravascularly, not perivascularly, and ensuring patency of the catheter. This would be informed to the attending veterinarian on the case and recorded on the patient's hospital chart as well. Now, I'll just record all of that information on Lexi's hospital chart. So we had her at 40 mils an hour and we started those fluids at 9:30. It is imperative that the correct time and fluid rate is written on the hospital chart to allow for accurate monitoring and timely intervention to the fluid plan if necessary. It ensures that the patient is receiving the correct volume of fluids they require while being in clinic and provides a clear and accurate record for them. It also helps to maintain clinic compliance with government rules and regulations. So to begin, we want to remove all of the sharps correctly in the sharps container here. To do that, we'll remove the protective casing of the catheter, dispose that in the general rubbish bin, and removing the sharps directly into the sharps container there, not placing our hand anywhere inside the sharps container. Then, using our metho swab, we'll discard that in the general rubbish bin unless it has been contaminated, and that would be deemed clinical waste. For the clippers here, as per our clinic policy, between each patient, we use a toothbrush to get in between the blade teeth here to remove any of that loose hair, oils, or foreign debris that may be built up from our last patient. Getting inside, using the toothbrush to clean the inside of the mechanism. Then you want to get the clipper blade itself, and on the inside, remove any of that hair, loose hair from the teeth, or any oils stuck between the teeth. Then we want to place that one back on, making sure it's working, it's functioning properly. Now, at the end of the day, as per our clinic policy, we use our blade lubrication oil here. We lubricate our clipper blades and then we run and test them for 20 seconds to ensure that they are functioning correctly and working properly. That is everything today. That is ACVN, Practical Assessment 23, setting up for catheterization, fluid therapy, and connecting a patient to fluids.